Anand Vinekar. So Dr. Anand Vinekar, please.
Thank you, sir. Thank you for considering my request to reschedule that talk. In keeping with the interest of the keynote address is typically a presentation made the previous year, so I've not really changed it, and I'm going to present it exactly from what happened last year. So I have no commercial interests. So first of all, the paper is about talking about a new device that can actually screen for ROP using a low-cost imaging device. So why do we need it? So the problem statement is the fact that when we began this program over 10 years ago, and even now nothing much has changed, there are more than 35 lakh babies born preterm every year in India. And that's the #1 country across all countries. And the Indian ROP Society has less than 150 specialists, less than 100 of whom are actually comfortable with treatment. What we started off about 10 years ago was taking this RedCam shuttle into the rural neonatal intensive care units. These images were being taken by non-doctors, whom we call non-physician trainees, who took these pictures and also were taught to report these images then and there. And then they uploaded these images on a telemedicine platform for the ROP specialist to look at on his or her smartphone. What started off as 3 hospitals has now grown to about 107, now it's about 112. And over 1 lakh babies have been screened, and close to 2,000 babies now have got treated, and the entire state has been covered. 2 years ago, almost 3 years ago now, the Supreme Court said that ROP screening is essential newborn care. In other words, if we don't screen, we're going to be liable for medical legal liability. So with this program expanding to several other states and even some other countries, what was the barrier for scaling it up? Well, the cost of the camera. It's 85 at the conservative attempt. If a government segment buys it with the AMCs, it goes to almost ₹1 crore. And if you have to have this camera travel around, it's quite expensive. So the invention that we started off with was actually, was the aim of the study, to report this new Indian invention. It came under the Make in India scheme. It's a low-cost infant retinal camera, and we wanted to, in this study, compare it with the gold standard, and most importantly, look at its economic benefits. We teamed up with an industry partner in Bangalore city called Forus Health. You all are aware of their other products, and with IIT Chennai, and with Department of Biotechnology, Government of India. As you know, the Prime Minister's favorite scheme is the Make in India scheme. So it really came under that. And the R&D actually started much before this government. So it started off with making some prototypes, first in thermocol and then in plaster of Paris, and then actually improving the whole form factor so that it could mimic without doing any reverse engineering of the so-called gold standard. The initial devices about 3 years ago were not really what we wanted. They were quite bulky, and they were not as good in terms of illumination and in the field. Then the first prototype came in about early 2015. It was much bulkier, and the images were okay, not too good, especially in the peripheral retina, where the illumination was so much that a lot of the vascular detail was getting sort of blurred out. We then had to go through a very extensive safety trial where not just the biosafety but phototoxicity, etc. had to be tested, and a very stringent ethics committee approval had to be got. This work is actually submitted and is looking for a publication. And after the ethics committee, we then looked at a study which tried to compare it with the gold standard. So this is the current handpiece that's available in the market. It's now FDA and CE approved for more than about 18 months now, and more than 20 installations in the country so far, but not that many when this presentation was made last year. So you can see the blood vessels are now reaching the edge. You can take up to the periphery, which is about 120 degrees. The RedCam is 130, and this compares pretty well. Also, more importantly, this device sits in a small briefcase and is much more portable. It was not made with reverse engineering. The engineers did not break down the RedCam and invent it from backwards. There were at least 2 new innovations in terms of the lens. So they used a liquid lens, and instead of using a halogen light, they used an LED light. Also, the entire photograph that you see is a much larger circle compared to the sort of cutout ends that you get from the RedCam. So from the Neo, you were able to get this superior and inferior retina extra. Of course, the cost was much lesser. It was about 12 to 15 lakhs, and I think that price is scheduled to come down further compared to the 85 lakhs that we spoke about, and that's the size difference. Now, since one was a circular image and one was a sort of cut-off image, if we had to do a mass study, we had to crop these images. So that's what was done. and these images using a software had to look like each other so that the readers did not know from which device these images came. And then it was presented to 2 ROP specialists sitting in different parts of the country. Over 1,000 babies were actually enrolled into this study. There's nothing big deal about the gestational age and the period and the birth weight. It was just comparable. But here's what you really want to see. So on top is a picture taken by the new camera, and you can see the early sort of stage 2 in zone 3, and the same thing is picked up by the gold standard. So a reddish hue compared to a bluish hue, and a red is what actually the blood vessels look like. So this was more natural form. These are vessels not showing you disease, but to show you what the blood vessels reach at the edge. So this is the same baby taken at the same time. This is an immature retina, and that's a mature retina, to show you that this is a wide field image. These are uncropped images. So this is a stage 3 in about zone 2 on the RETCam, and the same baby at the same time taken on the NEO, and this is the full circle that you get to see. So the limitation was that we have not really got excellent results in any of those lesions that are protruding into the vitreous cavity. So we were scared that vitreous seeding, let's say in a case of retinoblastoma, might be missed out. Also, we had not, at least at that time, tested it out on older and heavier babies, but currently that limitation has been met. And finally, since the study was done in Bangalore and in around Karnataka, it's just a single race and ethnicity. The sensitivity improved, rather it was almost stable from the initial 140 babies to the 1,000 babies. The sensitivity was in the 90s, but the specificity was really low to begin with. It was about 40%, and that has improved to 78. But as another 2,500 babies have got added in the past 1 year, this is looking to the high 80s or even early 90s. So the community benefit, finally a device is important because we wanted to make a difference in the community. So the cost benefit analysis, so for this we engaged few specialists from Indian Institute of Management or IIM Bangalore within our city, and they did a very extensive cost effective analysis. I'm going to just get into their summary. So set up a new program, let's say there's no ROP program in a particular place, so set it up, it would be just 20% of the current costs, and to keep it running it would be 50% of the current cost. So that's still high, and obviously we need to look at how to reduce that further, but then it's a significant reduction. This means that for the whole state of Karnataka, where we're looking at an average of about 18,000 sessions in the current KIDRA program, this would mean we are able to reduce the cost 6-fold, and almost 5-fold would be the reduction in the recurrent costs. So as this entire program has now got validated using the CDC guidelines, and taking from that report which was done, and this report was submitted to Government of India, it says that if you go back to indirect ophthalmoscopy, it might be suboptimal care and you might be inviting a medico-legal problem. Also, Government of India is now for the first time actually recognizing wide field imaging as an actual alternative for indirect ophthalmoscopy performed by ROP specialists, but it's not mentioned who and how they can do it. But with lowering costs, that might be important. And with proliferating number of newborn care units across the country, both in the government and in the private sector, on the left you see the RETCam, how we used to move it around into the rural centers, and how much smaller a vehicle and much easier it is, portable it is to carry the current device. So in conclusion, so far, the blindness that we have prevented in Karnataka state, and this number has increased now, is about 450 crore of blindness potential if you multiply the number of babies saved by the per capita income and the life expectancy. If we use the NEO, this would be upwards of 2,000 crores. So that's the impact you can make to the community. And how much more can we prevent? This paper then subsequently has got published in the IJO. If you just expand this program to 9 high-risk states, we will be preventing a burden of more than 3,500 crores if we use the lower cost model. Finally, it's about, for us clinicians, it's about the children or the babies that we take care of. This baby was detected to have a zone 1 ROP about 8 years ago on the RETCam, on the American camera. And now she's grown up, and this is her younger brother who was picked up about 2 years ago using the NEO camera, and life comes back a full circle. And we're very happy that we are able to make a small but significant difference in the lives of these children. Thank you so much.
Thank you, Dr. Anand. I thought there are few bottlenecks in your study. One, you have already highlighted
this
some
is
of
not
the...
in the competitive section, sir.
Some of the...
Oh, okay, sure. Yeah, sure.
I know it's a keynote address,
yes,
but it's a wonderful topic. It is of the immense interest to the audience, so I was just trying to interact with you.
Please.
And have something to learn more from this. It's a wonderful study you have presented, but there appears to be some bottlenecks. One, the limitations you have already highlighted. Two, it is limited to Karnataka only. So would you like to associate yourself with AIOS and undertake some national level project and try to, get some legal, acceptance of it? Because ROP, you have rightly mentioned 1.5 crore rupees penalty was declared by the Supreme Court. So how would you look into this?
The limitation, I'll answer in two parts. The limitation of the camera is being met. This was a year ago, and now the newer versions have even better illumination and mid-vitreous focus as well. As far as expanding beyond Karnataka, we have been training states outside Karnataka since 2010. Already 8 states are trained on our model, and that includes Tamil Nadu, Kerala, Pune, Lucknow, and now Madhya Pradesh, and very soon Chhattisgarh as well. So we are at the national level. In fact, a group of us belong to the Indian ROP Society, and that is now creating a sort of a platform where all the ROP specialists across the country are going to be accredited as screeners and treaters. And this is going to be the medical legal document, because neonatologists don't know whom to refer to, and a lot of treatments happen sometimes which may not be required. So the society is trying to look at bring out stringent accreditation values. So it is going on, and now in Karnataka, the new model is to train nurses to take these pictures and using the low-cost camera, and that also is expanding to other states.
Okay.
Thank you, Dr. Anand, for your
interest to Dr. Anand Vinekar. This project was funded by Department of Science and Technology. Incidentally, I happen to be the expert on the panel who gives the grants. Forest people got 24 crores rupees interest-free loan. So if anybody amongst the audience or you yourself got an idea about it, instead of collaborating with the forest, one can himself can present it, and government in India is full of
funds.
That's what I was trying to mention. Sid, why not to move it through AIOS? No, or MCI or any other. Some.
CDB is a different body. Ministry of Science and Technology. That is called Technical Development Board. Doesn't have any link with MCI or AIOS. You have to present your novel idea, what way it can benefit the India, and if your project fulfill. Forest got 24 crores rupees free interest.
I see.
And it is many times is a grant. You ask Forest people. I was there on the panel. They got the grant. Right? Many times you need not to pay also. It is grant, something like that. But to be some cost charges. Otherwise, everybody will run away with the money. They just put, I think, 1% or 0.5% or expensive charges or so.
Right.
That's a good idea. Maybe instead of industry, a doctor can himself put up an idea.
I think Dr. Shrikant's idea is well taken up. Thank you, Dr. Anand. Thank you for your wonderful keynote address. Now we go